goes back and it resumes a flat area in about 1 to 2 seconds, okay? If you got a dehydrated person, Yusef, that tint that you called it, and we call it skin tinning, will stay up there for 5 to 10 seconds. Why? Because the fluid has been shunted away from the skin. And this tells us that our patient is going to have be dehydrated. You can look at their eyes many times. If the eyes look kind of sunken and hollow, that's an indication of severe dehydration. That generally, Jack, is going to take several days for that position, that particular thing to happen. Look in their mouth, okay? The mouth obviously should be nice and moist, but if you see kind of like fuzz on the tongue, because that's what happens when the mouth gets dry, that's another indicator that we've got an issue going on with dehydration. When we're dehydrated or when we're in the early signs of shock, basically what we're looking at is one of the first things happens is that the heart rate will go up. And the heart rate, Yusef, may be as high as 15 to 20 beats above what a normal resting pulse would be for this patient. Now, most patients are not going to know what their resting pulse is. If you ask me what my resting pulse is, I have no idea, okay? I suspect it's probably somewhere in the 60s because I take a beta blocker. But I don't know what that is. But if I was in shock, my heart rate would go up at least 15 to 20 beats per minute to help to maintain that blood pressure. The other thing that we're looking at here is, remember we talked a little bit about the way the body reacts so that at the end of the class, when you're set free and you stand up and you get ready to leave, you don't pass out because the body is able to vasoconstrict and keep blood going to your brain to maintain your balance. There are some patients, and there is some debate as to whether this exists. I've looked at the research. I think that it is still a valid assessment tool of called positional hypotension, okay? When you stand a person up from a sitting position, their blood pressure may fall and their heart rate goes up. That's typically an indicator that your patient is in shock from some type of etiology, okay? For a lot of patients, it's just simply because they're going to be dehydrated and they're not able to maintain their blood pressure. So that's something you just kind of want to keep in mind. When you're transporting your patients, if they're in shock, keep them nice and flat, okay? You may have heard of the Trendelenburg position where you raise the legs. We don't do that anymore. It doesn't work. It can actually, in some patients, cause harm to them, especially if they have some type of a head injury or if they have some type of a respiratory issue. It can actually make their respiratory status worse. So we want to kind of keep them in that nice flat type of position when we're looking at that. So that is hypotensive type of shock, okay? Now, let's talk about distributive shock. A distributive shock. Distributive shock is caused by massive vasodilation in the body. You've seen this slide before. You notice that over here on the left, we have a nice, round, constricted, basically what we're looking at here is we're looking at the arteries. And as a result of that, the blood fills the artery and the pressure is perfect for perfusion within the body. The picture next to it is a graphical representation of this same artery, except now we've got really severe vasodilation. That's the same amount of blood that you have over here in this artery, but with this patient here, the patient's blood pressure is going to fall. Again, Zach, it's because there's not enough blood to fit the size of the container to maintain that pressure. We use the example of a fire hose on Monday to illustrate that and to see that it would cause a problem. Distributive shock, again, can come about from a number of reasons. I'll give you some examples of these in just a minute, but one of the things is we just have this massive vasodilation. In some situations, like we talked about with anaphylactic shock, not only do we have massive vasodilation, but the vessels themselves now begin to get leaky. They begin to pull that plasma out, and this volume that is inside this dilated vessel now becomes even less. So, again, keep in mind with distributive shock, there's two problems with it: dilation and leaky vessels, okay, as far as it's going in there. When we're seeing this, as a result, the circulating volume that's within the body just kind of sits there and pools. It's much like you said, Yusef, a while ago. It just kind of sits there, it's not moving. And one of the bad things that happens with blood, when it doesn't move, those of you that are in my cardiology class, we talked about this yesterday actually with atrial fibrillation. You've heard of atrial fib. Basically what happens, the problem with atrial fib is that not all the blood gets ejected from the top chambers of the heart. When blood sits still, it has a tendency to clot. And the exact same thing can happen in distributive shock, that your patient's blood begins to become thick and it begins to clot, leading to a whole host of other problems. But the end result here is that perfusion does not occur. Now, there are 3 specific types of shock that are classified under distributive shock. And we will go through each one of these in its own section. So right now, all I want you to know are the names of the 3. One, we've already talked about, anaphylactic shock. There's a second one that's called septic shock. Septic shock comes about as a result of a massive, severe infection in the body. The body gets overwhelmed, James, and as a result of that, blood vessels now begin to dilate, okay? So septic shock. Third one is called neurogenic shock. Neurogenic shock. Neurogenic shock comes about as a result of some type of, usually, a spinal injury, Jaquan. And as a result of that, there is a disruption between the blood vessels and the brain. Remember that the brain is what sends out the signal, okay, now you need to constrict or now you need to dilate, all right? In neurogenic shock, that signal gets interrupted. The transmitting lines are broken, okay? The internet of the body goes down. And so the brain doesn't get the signal, doesn't realize that we've got this dilation that's going on. And basically, normally what the brain would do when that occurs is that it would send out signals for the other vessels to begin to constrict, to compensate for that. But the brain never gets that message. And as a result of that, all the blood vessels dilate and our patient goes into shock. Again, remember those 3 types and those brief descriptions that I shared with you, okay? But now, before I move on from distributive shock, any questions on that type of shock coming from you guys? Okay. Next type of shock, which is a common type of shock. Oh, yeah, go ahead.
What kind of infections lead to septic shock?
Any infection. It can take, so for example, let's take COVID. You know, it was in all the news. Maybe you heard about it. COVID, for a person who is normally healthy, is basically an inconvenience. But if you have a person that has some type of other medical issue, cardiac respiratory, pick one. It doesn't matter which. Pick one. As a result of that, or if they are immune compromised from whatever reason, organ transplant, a disease process, now what happens is it comes in and it overwhelms the body, and your patient literally becomes septic. We see this a lot with older patients Again, typically, young people don't get urinary tract infections. That happens later on. But for the elderly, and for most people, for middle age or and on up, UTIs are basically a nuisance. They're painful, they're uncomfortable, but this too shall pass. But you get a UTI in an older patient, a lot of older patients die from those. They become septic because their body can't fight it off. So literally, it could be just about any disease process that can overwhelm the body, leading to sepsis. Our body does a pretty good job of fighting those off, but sometimes the infection is too strong or the body's defense is too weak.
Does it happen like if somebody already has like damage to like a certain organ, or like maybe an infection in a certain organ?
Oh yeah, you're exactly right. And a lot of it depends upon, again, have they been exposed to that pathogen before, whether it's a bacterial or a virus? And then again, are there things that depress their immune system that keep the white blood cells and the T cells from multiplying to be able to go in and begin to fight that infection off? So literally, there's a lot of switches that the body has to switch on and off when an infection occurs. And if they're not all switched on at the right time, then a patient, in any of us can be susceptible to that, can become septic. Okay, good. That's your point.
So what is the common go to shock from having like a burn or something?
That would be distributive shock, okay? Again, because you're losing fluid out of the vasculature, okay? You're not losing blood, but you're losing the plasma, all right? Cardiogenic shock is the next type. This is a very familiar, very common type of shock that cardiac patients will go through. Keep in mind that the heart is a pump, and as a result of this pump, it requires a certain amount of action from the heart in order to get blood out of the heart, down to the big toe, and then back to the heart as far as when it goes. Now, there's a bunch of different diseases that can cause the heart to stop pumping effectively. I'm not going to ask you to memorize all of those diseases in this particular course, but we'll look at some of them as we progress on through the rest of the semester. Within certain limits, the heart is pretty good at adapting or fighting off these diseases so that it's able to maintain itself as an effective pump. But if the heart becomes damaged beyond a certain percentage of the heart, and specifically, and this is going to be important that you remember because I suspect you'll see this on an exam, specifically the left ventricle, because the left ventricle makes up, James, about 75% of the heart. So if the left ventricle has a certain amount of damage, and how much it takes doesn't really matter, but the pumping action of the heart now begins to fail, and as a result of that, your patient can go into shock. This type of shock is known as cardiogenic shock. Basically what happens here is that filling of the vessels is impaired because preload, or the amount of blood that is brought back to the heart, is reduced. Why? Because the heart cannot contract effectively. The most common cause of cardiogenic shock is an acute myocardial infarction.